Hello everyone, this is Ms. Page, and this lecture will cover inflammatory heart disorders. Objectives for this lecture are going to be compare and contrast the etiology and pathophysiology, clinical manifestations, assessment, diagnostic tests, medical management, nursing interventions, and prognosis for patients with rheumatic heart disease, pericarditis, and endocarditis. Identify conditions that may result in the development of cardiomyopathy, and discuss the indication for cardiac transplant. So our rheumatic heart disease is going to be the first one we'll talk about. Rheumatic heart disease results from rheumatic fever. And rheumatic fever is caused by a strep infection, usually during childhood, that is not treated well enough. Your rheumatic fever is going to be more common in developing countries, overcrowded living areas, and in the winter months. About 90% of the patients who have rheumatic fever are between 5 and 15 years of age, so it really hits hard in that pediatric, adolescent age group. Antibiotics are going to treat rheumatic fever, especially penicillin. And what causes the rheumatic fever is ineffective treatment. So maybe the child doesn't get antibiotics for long enough. Maybe they stop taking them when they start to feel better, or for some reason the treatment wasn't effective. And that's going to result in inflammation of the cardiac tissues, the central nervous system, the joints, the skin, and subcutaneous tissues. It really affects the whole body. And basically, their body makes antibodies to fight off the strep infection, and then after that strep infection is gone, the antibodies are still there, and the body starts to think that the connective tissue is the strep, and then it starts to attack the connective tissue, so it starts to attack the body. Usually the onset of this is sudden, and it's usually going to occur 1 to 5 symptom-free weeks after recovery of that strep. And it can also go undiagnosed and untreated, and then years later you can develop symptoms, which is where we get into that rheumatic heart disease. So your rheumatic heart disease is going to be caused by rheumatic fever. Basically, the cardiac tissue develops small areas of necrosis, and then they heal and leave scar tissue behind. So then you've got scar tissue in the heart valves, which the scar tissue in the heart valves, those are known as Ashkoff's nodules, Ashkoff, Ashkoff's nodules. And then once you have scar tissue in the heart valves, then that's going to make them more fibrous. It's going to make them harder to close all the way. They're going to get thickened and deformed, so that can cause your stenosis and regurgitation. Your complications of rheumatic fever are going to be heart failure, pericarditis, pericardial effusions, aortic or mitral valve regurgitation, and also permanent cardiac damage. Down here at the bottom of the screen on the right, I have this diagram. So basically, it's kind of a visual for rheumatic heart disease. So first, the body gets introduced to streptococci, and then that can turn into strep throat. If the strep throat is undertreated or not treated, that can turn into rheumatic fever. And then after you have the rheumatic fever, it can turn into that rheumatic heart disease, which can lead to heart valve damage. Your assessment of a person with rheumatic heart disease, there's subjective and objective. So subjective, they'll probably complain of joint pain or arthritis because that body is attacking that connective tissue at the joints. Chest pain, lethargy, or fatigue. Your objective assessment, so you're going to see like small erythematous circles and wavy lines on the trunk and the abdomen. These are known as erythema marginatum. And there's a picture of that on the right-hand side of this slide. They might also have involuntary purposeless movement of the muscles. This is known as chorea. That you might hear a heart murmur. They might have a fever, an increased pulse, epistaxis, which is a nosebleed or anemia. And then you'll also note nodules on the joints, like the knees, the elbows, or the spine, and subcutaneous tissue. Your diagnostic test, so usually it's going to go by signs and symptoms. And then an echocardiogram can also be used. This is going to show the extent of damage to the valves and the heart muscle. EKG can be used to diagnose any kind of dysrhythmias. Heart sounds will indicate if they have a murmur or a friction rub. Leukocyte counts, serum antibodies that are against streptococci, just to kind of get a base level of the serum antibodies. Management is going to be preventative measures mainly. So rapid treatment for a pharyngeal infection. So if the child has any kind of signs and symptoms of strep, sore throat, fever, cough, rapid treatment is going to be the best way. So preventative measures. If they have rheumatic heart disease, you want them to have bed rest if needed so that it can decrease that workload on the heart. NSAIDs and heat for joint pain, a well-balanced diet. They need high volume fluid intake. And then if it's bad enough, they can have a surgical commissurotomy, which was when they basically go into the heart and they cut that fibrous valve to make, like, they cut back on that scar tissue, on that scarring, the stenosis, the thickening, to make it a wider valve so that the blood flows easier through it. Or they might need valve replacement. Nursing interventions for rheumatic heart disease. You want them to have proper positioning for the joint pain. And when you're moving them, you want to be easy on their joints. So hold the joints with your palms instead of your fingertips. You want to organize their care so that they have rest periods and periods of uninterrupted rest. You can provide diversional activities that help promote rest, such as reading a book or watching TV, listening to music. You might need to offer them some emotional support. You want to offer them teaching, so help them understand the disease. You want to help them understand their activity limits because their heart is not pumping as well as it needs to, so they might have to cut back on that exercise or those activities. And then signs and symptoms of worsening of the disease. Usually during childhood and adolescence, if they have rheumatic fever, they're going to have daily prophylactic penicillin by mouth, or they might get monthly injections. And basically that's just to help with the rheumatic fever and the strep infection. And then they always need to have prophylactic antibiotics before surgery or dental procedures, just so that they don't run the risk of getting another kind of infection or that rheumatic fever flaring up. Next disease process we'll talk about is pericarditis. So we know the pericardium is that membranous sac that surrounds the heart. So your pericarditis is going to be that inflammation of that sac surrounding the heart. What the pericardium does is it helps provide lubrication to decrease the friction during systole and diastole. So when the heart is pumping, it helps decrease friction. The constriction and the thickening of the pericardium is going to occur gradually, and then it causes compression on the heart, and that prevents normal filling during diastole. And sometimes if it's bad enough, they might have to have surgical removal or surgery on it. So pericarditis can be acute or chronic. Bacterial, viral, or fungal infections are usually associated with your acute pericarditis, and fibrosis is often associated with the chronic form. It can also occur as a complication from maybe if they had a heart attack or if they have trauma after thoracic surgery, if they have lupus, radiation, any kind of drug reactions. All of those things can cause pericarditis. Your manifestations of pericarditis are going to be chest pain, and it's going to be pain that really mimics a heart attack. but the pain is going to be worse when they're lying supine, if they take deep breaths, if they cough or swallow, or any kind of movement in the trunk area. And it's going to be alleviated when they sit up or they lean forward. Another manifestation is going to be decreased heart function. So normally you have about 15 to 20 mLs of fluid in the pericardium, but a person with pericarditis has 150 to 200 mLs of fluid. So that's a lot of fluid that's going to be pressing on the heart. For your assessment, you'll have subjective and objective. Subjective, they'll probably complain of muscle aches, fatigue, and dyspnea. They might also complain of anxiety, anticipation of danger or uneasiness. Objective, so what you see, they'll have substernal chest pain. It might radiate to the neck. They're going to be in that orthopnic position where they're sitting on the side of the bed with their elbows up on a table, leaning over to breathe. They might have fever, shortness of breath, chills, sweating, diaphoresis, a non-productive cough, rapid and forcible pulse, rapid shallow breathing, and one of your most common signs and symptoms of pericarditis is going to be a pericardial friction rub. So it sounds like a grating, a scratching, or a leathery sound when you listen to it with your stethoscope. And they might also have dysrhythmias. Diagnostic tests used with pericarditis, so they might need an EKG to kind of rule out any kind of dysrhythmia, or if they do have a dysrhythmia, an echocardiography or echocardiogram. This is used just to check if a patient has pericarditis, if there's the inflammation around the heart, and that can cause a pericardial effusion or cardiac tamponade. So this echocardiogram is going to help kind of aid in the diagnosis of that. Leukocytosis, they're going to have an elevated white blood cell count, so they'll get blood on them. Their erythrocyte sedimentation rate, or ESR, is going to be elevated. They might need blood cultures just to find out exactly what kind of bacteria or virus or fungus is causing this. They'll get cardiac enzymes just to rule out a heart attack and make sure that there hasn't been any cardiac damage. C-reactive protein, or CRP. This, if the levels are elevated, it indicates that inflammation is going on in the body. So that will help in the diagnoses of pericarditis. And then a chest x-ray, but with your pericarditis patients, usually that chest x-ray will look normal. So you'll have to do those other diagnostic tests to really get an answer. Medical management is going to be analgesia because they've got a lot of chest pain, oxygen and fluids, antibiotics, but only if the cause of this is bacterial. Anti-inflammatory agents or corticosteroids to help with inflammation. And they might, if it's bad enough, need a pericardial tap or a pericardiocentesis. This basically removes excess fluid and restores the normal heart function. And there is a picture of it on the right-hand side. Basically what they do is they stick a needle into the pericardium and they drain that fluid off by pulling back on a syringe. Your nursing diagnoses and interventions for pericarditis. So they are at a risk for decreased cardiac output because that fluid's going to be pushing on the heart, so the heart's not going to be able to beat and relax as much as it should. They're going to be at a risk for infection, especially if they have that pericardiocentesis. There's going to be a needle that is stuck from the outside of their body into their body, so there is a risk of infection for there. Ineffective breathing pattern, pain, activity intolerance, and anxiety. Those are all possible nursing diagnoses. Your interventions are going to be to monitor vital signs, auscultate lung and heart sounds, because you want to know if there's any kind of change with your patient. They will probably need bed rest to decrease the workload on the heart, elevate the bed to 45 degrees because it will be easier for them to breathe if they're elevated. Hypothermia treatment might be necessary, and you want to stay with your patient if they become anxious, and make sure to explain all procedures to them. Next disorder we'll talk about is endocarditis. So the endocardium is the lining of the heart. So this is the infection or inflammation of the inner membranous lining of the heart, the endocardium, and particularly it's going to affect the heart valves. Infective endocarditis is going to be from the invasion of an organism. Usually it's going to be bacterial, but it can be caused by fungi, viruses, anything like that. Basically what happens is organisms are going to be deposited on that heart lining or on the valves, and then they will embed into the tissue, and it causes vegetative growth, and then that growth can cause ulcers or scarring. The growths can break away and cause an embolism, an infection, or an abscess. Left-sided heart vegetation, that can cause an infarction to an organ. And then right-sided heart vegetation can embolize to the lungs. So let's think about this. If you have vegetation on the left side of the heart, the blood is flowing from the left atrium to the left ventricle, and then it goes to the aorta and the rest of the body. So basically, if something breaks off in that left side, it can travel to the body, and that can cause any kind of infarction to an organ, or it can cause an embolism in an organ. Then your right-sided heart vegetation, it's going to go from right atrium to right ventricle, then it goes into the pulmonary artery. So right-sided heart vegetation can cause embolisms in the lungs. Risk factors, contributing factors for endocarditis is going to be rheumatic heart disease, congestive heart disease, degenerative heart disease. Prosthetic valve endocarditis can be caused from valve replacement, IV drug users, unhealthy teeth and gums, and this is because it allows bacteria to enter the body easily through there. Any kind of invasive dental procedures, because bacteria that's harbored inside the mouth and the gums can become dislodged, and that can cause an infection. Minor surgery, needles used for tattooing or body piercings, and insertion of indwelling urinary catheters that can cause a UTI, can lead to endocarditis. Assessment, subjective, they're going to complain of general flu-like symptoms, so fever, fatigue, headache, chills. They might have joint pain, and they might also complain of chest pain. Objective assessment for endocarditis, you'll find petechiae in the conjunctiva, oral mucosa, the neck, the anterior chest, abdomen, and legs. And you can see on this slide, this petechiae up in the right-hand corner, you see that those small red dots in the conjunctiva. So you can see that in endocarditis. Splinter hemorrhages in nail beds, those are black longitudinal streaks. You can see a picture down here of these splinter hemorrhages. Non-tender macular lesions, which are like flat reddish spots on the palms and soles. These are known as Janeway's lesions, so you can see it right here on the very right. You'll get these small, non-tender lesions, like flat reddish spots. That's going to be on the palms and the soles of the feet. And then you'll have tender, red, elevated nodules on the pads of the fingers and toes. This is going to be from microemboli, vasculitis, or in an embolism. So these are known as Osler's nodes. So your Janeway's lesions, these are non-tender and flat reddish spots. Osler nodes are going to be tender, raised red spots, nodules. They might also have weight loss, a rapid pulse, and heart murmur. Diagnostic tests, so you'll want to get a little bit of health history. You'll also get blood cultures to kind of figure out what infection is causing the inflammation. EKG changes can signal endocarditis. Chest x-ray, leukocytosis, so an increased white blood cell count, increased ESR, anemia, Medical management, you want to support the cardiac function, so rest. That's going to help decrease the heart's workload. They might need a valve replacement. You want to just destroy the pathogen that is causing this problem. So antibiotics, and they can be on antibiotics from 1 to 2 months, if not longer. Prevention of complications is also another big one. You want to make sure that any of this vegetative growth doesn't break off and travel, because then it can go to the brain and cause a stroke, go to the lungs, cause a pulmonary embolism, go to the coronary arteries and cause a heart attack, anything like that. And usually it's going to occur after the first 2 weeks of the diagnosis of endocarditis. Antipyretics can also be used if they have a fever. Prophylactic antibiotic treatment is needed. Anybody that's at a high risk for developing infective endocarditis, so before a dental procedure, even before a minor surgery, if they've had previous valve surgery, if they have a pre-existing valvular heart disease, all of these patients are going to want to be on prophylactic antibiotic treatment. Nursing diagnoses and interventions, so they can have hyperthermia, so elevated body temperature. You want to make sure to record their temperature every 2 to 4 hours, obtain those blood cultures if needed, and you want to make sure to get the blood cultures before you start the antibiotics. And then provide anti-inflammatory or antipyretics as needed. Ineffective tissue perfusion can also be one of your nursing diagnoses. So you want to assess and report any kind of manifestations that come along with decreased organ system perfusion. So change in level of consciousness if they're having decreased oxygen to the brain. Decreased urinary output if the kidneys are struggling to get oxygen. Dyspnea, chest pain, tachycardia. You want to assess the skin color, the temperature, quality of peripheral pulses, and the cap refill, especially with your skin. You really want to look at the skin because they're going to have that petechiae. They're going to have those Osler's nodes. They're going to have those Janeway lesions. So those are going to indicate and clue you into the development of endocarditis. They might need to decrease their activity to help with that workload of the heart, provide a calm, quiet environment, and promote rest and comfort. You want to encourage adequate nutrition, so give them attractive meals, maybe between meals snacks, and encourage good oral hygiene. Next, we'll talk about myocarditis. This is inflammation of the myocardium, so inflammation of the heart muscle. This is I wouldn't say very rare, but it's relatively rare. Usually it's going to be caused from rheumatic heart disease. It can also be caused by viral, bacterial, or fungal infection, or endocarditis or pericarditis. Most of the cases of myocarditis that you see in the U.S. are going to be caused by Coxsackie virus type B. So the clinical manifestations, you really have early symptoms and late symptoms. So your early symptoms are usually going to occur 6 weeks before the patient has signs and symptoms of myocarditis. So upper respiratory tract infection, so fever, chills, sore throat, abdominal pain, nausea, vomiting, diarrhea, myalgia. So these are very general symptoms, and they can really go with any kind of disease. Those are going to be your early signs and symptoms. Your late signs and symptoms are going to be chest pain, heart failure with dyspnea, cardiac enlargement. You might hear murmur, a gallop, or they might have tachycardia. They might have cardiomyopathy, which we'll talk about here in a second, and they might develop some dysrhythmias. Diagnostic test, you're going to want to get a chest x-ray, get an EKG, an echocardiogram, maybe an MRI, and then possibly a cardiac cath to get a myocardial, like a biopsy, to kind of figure out what's causing that inflammation. Medical management is going to be for symptoms, so bed rest, oxygen, antibiotics, anti-inflammatory agents. You want to carefully assess them notice any kind of sudden or not so obvious signs and symptoms or changes from baseline, and then the correction of dysrhythmias if they develop any. The goals are going to be to preserve that myocardial function, because remember, when your myocardium, when necrosis, tissue death occurs, it doesn't come back from that. So you want to preserve that function of the heart. You want to prevent heart failure. And this disease can be long. It can be a long benign course, or it can happen and there's sudden death with exercise. So it kind of varies with myocarditis. Patients can also recover and then later develop cardiomyopathy, which is what we will talk about next. Cardiomyopathy, it's a group of heart muscle diseases that are going to affect the structure or the function of the myocardium, of the heart muscle. So we've got primary cardiomyopathy and secondary cardiomyopathy. And then your primary cardiomyopathy is broken down even further. So primary cardiomyopathy is going to be, there's going to be the cause of this is unknown. So you have your dilated cardiomyopathy, which is the ventricular dilation, which is going to be your most common. And there's a picture of that, and that's going to be the middle one. So you've got your left ventricle is dilated, or your ventricle is dilated. Your hypertrophic cardiomyopathy, this is the increased size and mass of the heart because of increased muscle thickness and decreased ventricular size. So you can see there's excessive wall thickening of the cardiac muscle here. And then you can also have restrictive cardiomyopathy, and this is when the ventricular walls are going to be rigid. So this limits the ventricle's ability to expand, and it results in impaired diastolic filling, and it doesn't really pump out as well as it should. Secondary cardiomyopathy can be caused by a bunch of different things, but basically secondary cardiomyopathy, we know what the cause is. So it can be infective, so it can be caused by viruses, bacteria, fungus, protozoa. It can be metabolic. It can be from severe nutritional deprivation, so maybe if they have anorexia nervosa. It can be caused from alcohol. Chronic alcohol abuse can lead to dilated cardiomyopathy. It can be peripartum, so maybe in the last few months of pregnancy or within the first few months after delivery, secondary cardiomyopathy can occur. Drugs can cause cardiomyopathy, radiation therapy, lupus, rheumatoid arthritis, and then also cocaine, and this is going to be referred to as crack heart. You might hear it called that, but basically when the person snorts cocaine or however they do it, it's going to cause really intense vasoconstriction of the coronary arteries and the peripheral vessels. This causes hypertension. That increases the needs of oxygen in the myocardium, and there's not that much of a supply, so that can lead to a heart attack or ischemic cardiomyopathy. Also, cocaine can cause high levels of catecholamines, that's your epinephrine and norepinephrine, and that can cause damage to the myocardial cells even further. Clinical manifestations of cardiomyopathy, signs and symptoms. They will have chest pain, they might have syncope, fatigue, and dyspnea. They're going to have severe exercise intolerance. That's going to be your most common sign. And then they might have peripheral edema, ascites, hepatic dysfunction, so signs and symptoms of heart failure if it progresses. Diagnostic tests, you can use your EKG, chest x-ray, echocardiogram, CT scan, a MUGA scan, cardiac cath, or an endomyocardial biopsy. Medical management is going to be treating the underlying cause and then managing that heart failure that can occur with it. So diuretics, ACE inhibitors, antidysrhythmics, beta blockers. They might need an internal defibrillator. They might need a cardiac transplant. But they definitely want to avoid strenuous exercise, so we're not putting too much more workload on the heart because it's already stressed enough. Last thing we'll talk about is cardiac transplantation or cardiac transplant, heart transplant. The first one was performed in 1967. Heart transplant is going to be the treatment of choice for patients that have end-stage heart disease and that are unlikely to survive more than 12 months with the heart that they have. Your dilated cardiomyopathy is going to be the most common type of cardiomyopathy that requires transplant. And then inoperable coronary artery disease is going to be the second most common indication for transplant. The evaluation process for patients that are going to get on the cardiac transplant list, the goal is to identify patients that would benefit the most from a new heart. So they're going to look at their coping abilities, their family support system, the motivation that they have to follow through with the transplant and the regimen. Because after you have a heart transplant, it just doesn't just stop there. They have lifelong treatment that they have to be on. After being placed on the list, the patient is just going to wait at home and receive ongoing medical care. The wait is often a very long time, and most of your patients are going to die at home while they're waiting for a heart transplant. During transplant, cardiopulmonary bypass is going to be used during the procedure. They are also going to have immunosuppressive therapy before the procedure. So this is going to help reduce transplant rejection and slow that rejection process that can occur with transplants. Post-op care, they might have endomyocardial biopsies after the surgery to kind of get an idea of whether or not it's going to reject, whether or not the body's going to reject that new heart. And they'll also check white blood cells, red blood cells, really those T lymphocytes to check the immune status, and that goes along with the rejection and how the body is responding. Interventions, primary intervention is going to be prevention of infection because that patient is already immunocompromised. Usually if the patient has an infection, it's going to be that leading cause of death is going to be infection after transplant. You want to provide emotional support, definitely a lot of teaching, promote the patient to adapt to this transplant process. You want to help relieve any kind of symptoms they're having. Are they having pain? Monitor their response to the medications that they're taking. Definitely monitor their cardiac rhythm for any dysrhythmias. They need to avoid strenuous activity. They want to stay hydrated. They'll need to space activities out and allow for rest periods just so that new heart doesn't get overworked. Prognosis for heart transplant. So the majority are going to die within 2 years, but there is a 69% chance of survival rate 5 years after transplant. So it really just depends on how strict that patient is going to be with the regimen after transplant and how serious they are about this heart transplant. As your study tip, you should be able to compare and contrast the etiology and pathophysiology, clinical manifestations, assessment, diagnostic tests, medical management, nursing interventions, and prognosis for patients with rheumatic heart disease, pericarditis, and endocarditis. You should be able to identify conditions that may result in the development of cardiomyopathy and discuss the indication for cardiac transplant.